All right, this is part two of the JFK Autopsy report. I am Dr. Wolfe. I am a forensic pathologist medical examiner with over 3,000 autopsies worth of experience, many of which were gunshot wounds. And I have been asked to go over this report, which I am doing now. If you are interested in following along, you can go to archives.gov, type in JFK Autopsy report, and it should come up as a PDF. Now, I realize you probably can't read this on your phone unless you have excellent vision. Congrats to you if you do. But I have the autopsy report here with me, and I am going to be reading this word for word and then kind of editorializing when necessary. Now, this is part two, or rather, page two of the autopsy report. And very commonly on page two of autopsy reports, we'll either do an autopsy summary or there'll be a clinical summary. And in this case, the doctor chose to do a clinical summary. And so, what that means is that usually goes over things like what are the circumstances of death? What are the medical problems that could have been involved in the death? In this case, it's a trauma, it's a homicide. So, he was basically just rehashing what happened, but I'm going to read it. According to available information, the deceased, President John F. Kennedy, was riding in an open car in a motorcade during an official visit to Dallas, Texas on 22 November 1963. The president was sitting in the right rear seat with Mrs. Kennedy, seated on the same seat to his left. Sitting directly in front of the president was Governor John B. Connally of Texas, and directly in front of Mrs. Kennedy was Mrs. Connally. The vehicle was moving at a slow rate of speed down an incline into an underpass that leads to a freeway route to the Dallas Trade Mart, where the president was to deliver an address. 3 shots were heard, and the president fell forward bleeding from the head. Governor Connally was seriously wounded by the same gunfire. According to newspaper reports, Washington Post, November 23, 1963, Bob Jackson, a Dallas Times-Herald photographer, said he looked around as he heard the shots and saw a rifle barrel disappearing into a window on an upper floor of the nearby Texas School Book Depository building. Shortly following the wounding of the 2 men, the car was driven to Parkland Hospital in Dallas. In the emergency room of that hospital, the president was attended by Dr. Malcolm Perry. Telephone communication with Dr. Perry on November the 23rd, 1963, develops the following information relative to the observations made by Dr. Perry and procedures performed there prior to death. So, in other words, it sounds like he called the attending ER physician to ask him some questions about the case, which is typical. A good forensic pathologist will try to talk to the clinicians and get information. Dr. Perry noted the massive wound of the head and a second, much smaller wound of the low anterior neck in approximately the midline. A tracheostomy was performed by extending the latter wound. At this point, the bloody air was noted bubbling from the wound, and an injury to the right lateral wall of the trachea was observed. Incisions were made in the upper anterior chest wall bilaterally to combat possible subcutaneous emphysema. So, in other words, they noticed the gunshot wound, which also involved the trachea. The trachea is another name for, or the medical name for the windpipe. So, in other words, air coming in and air coming out. They made incisions in the chest to relieve what's called subcutaneous emphysema. That occurs when air dissects into the tissues, usually as a result of injury to the airway. So this is not a surprising finding. Intravenous infusions of blood and saline were begun and oxygen was administered. Despite these measures, cardiac arrest occurred, and closed chest cardiac massage failed to reestablish cardiac action. So again, this is a situation where cardiac arrest is obviously going to be in the report, but this was due to the results of gunshot wounds. And then it says closed chest cardiac massage. In other words, we would call that CPR today. Failed to reestablish the cardiac action. The president was pronounced dead approximately 30 to 40 minutes after receiving his wounds. The remains were transported via the presidential plane to Washington, D.C., and subsequently to the Naval Medical School National Naval Medical Center, Bethesda, Maryland, for postmortem examination. And if it was unclear in the first video, I said the body was taken to Washington. I may have said it was autopsied there, but it was transported to Bethesda for the autopsy. Now, we're going to continue with this. The page 2, we have the general description of the body is the next heading. And this is pretty much what we still do today. We do a general overall so that the person reading it can get a sense of what the body looked like, even if they didn't know who it was. The body is that of a muscular, well-developed, and well-nourished adult Caucasian male measuring 72.5 inches and weighing approximately 170 pounds. Why does it say approximate? Because many morgues do not have scales to weigh the body. So sometimes you have to visually guess what the weight is. There is beginning rigor mortis, minimal dependent livor mortis of the dorsum, and early algor mortis. So rigor mortis usually begins sometime between around an hour after death, and then it gets stiffer over the next several hours until it starts to release. 36 to 48, 72 hours later, it'll start to release. It also depends on a lot of different things, but the point is consistent with what we know of the timing. When it says livor mortis of the dorsum, that just means the back part of the body. And that's the settling of blood after the heart stops. Then the only force acting on blood is gravity, okay? And then algor mortis, it says early algor mortis. Algor mortis is the term for cooling of the body, okay? It's not a term you hear very often, but it's basically saying that the body was no longer body temperature and it was approaching room temperature. The hair is reddish brown and abundant. The eyes are blue. The right pupil measuring 8 millimeters in diameter and the left 4 millimeters. And we often see asymmetrical pupils when we have brain damage or brain injury. There is edema and ecchymosis of the inner canthus region of the left eyelid, measuring approximately 1.5 centimeters in greatest diameter. So edema, swelling, okay, and ecchymosis, meaning like a purple color of the inner canthus, which is going to be right here in the sort of the middle to the lateral part of the nose and in between where the eye starts, is the best way I can describe it here. And that is consistent with gunshot wound of the head. A lot of times you'll have fractures of the skull base and a little bit of that blood can leak down and it causes that ecchymosis to form around the eyes. There is edema and ecchymosis diffusely over the right supraorbital ridge with abnormal mobility of the underlying bone. So the right supraorbital ridge, and it may be flipped on your screen, but this is the right on me. Basically, it's saying the bone is fluctuant. So he's pressing in and the bone is moving, which means it is fractured. Then it says the remainder of the scalp will be described with the skull. There is clotted blood on the external ears, but otherwise the ears, nares, and mouth are essentially unremarkable. The teeth are in excellent repair, and there is some pallor of the oral mucous membrane. Pallor probably due to extreme blood loss. Head wounds tend to bleed a lot. Situated on the upper right posterior thorax, just above the upper border of the scapula, there is a 7 by 4 millimeter oval wound. This wound is measured to be 14 centimeters from the tip of the right acromion process, which is sort of on the shoulder here, and 14 centimeters below the tip of the right mastoid process, which is that little bump behind your ear there. Situated in the low anterior neck at approximately the level of the third and fourth tracheal rings is a 6.5 centimeter long transverse wound with widely gaping irregular edges. The depth and character of these wounds will be further described below. And this is the tracheostomy site. So the gunshot wound was extended by the ER doctor or the surgeon there to try to get a tracheostomy or tracheotomy. And that was actually a very bad thing for the forensic pathologist because we need to be able to see those wounds intact. This is a source of controversy. At the time, the doctor wouldn't have known. Certainly today, we don't want that to happen. And a lot of the forensic conspiracies around this involves the character of that wound, which we will talk about in future videos. But we are almost out of time now, and we will continue.